Welcome to week 6. Today we are looking at pulmonology and breast and then axilla examinations. This is a content from chapters 15 and 18 of your textbook. So our focus will be on identifying the anatomical landmarks, distinguishing from abnormal physical findings to normal findings, and then integrating preventive care and then health promotion as we have been doing over the past few weeks. So this is anatomy and physiology, which we'll not delve much into, but understanding like the anterior chest wall landmarks is the foundation of a respiratory assessment. For example, the sternal notch and sternal angle, also called as the angle of Lewis, serve as a critical starting points for counting the leaps and precisely identifying the locations of underlying lung, lobes, and heart valves. The sternal angle is a vital anatomical landmark as it guides us to, directly to the second rib bypassing the hard to palpate first lip, which is very hard to palpate. So from here, you can accurately map the anterior thorax. And furthermore, you can utilize imaginary vertical lines as you see on, uh, on the image on the slide. Some of those lines you can use like midi clavicular or midi axillary and scapular lines, which allow for precise and standardized documentation of your physical assessment findings. So let's take a look at the lungs. For example, the, the right lung consists of 3 lobes, which you can see on the image in front of you, and the left has 2 lobes. So these also accommodate the heart. So recognizing the exact surface projection of these lobes, the right and the left, and their dividing features helps ensure that you are auscultating all lung fields properly, avoiding some blind spots. Also note that using accessory neck muscles, as this is a prominent clinical indicator of acute respiratory distress if you notice that on your patient when you're assessing them. Health history is very important for patients with respiratory complaints because they can make them worse. So if before we do even the physical exam, always be able to tell the difference between a true respiratory pain or cardiac or gastrointestinal or musculoskeletal source of the pain because those may overlap and that's very common. So it's a good idea to ask some of the questions about the onset, duration, or characteristics of those symptoms, especially if they complain of pain and they complain of other symptoms like cough or dyspnea or daytime sleepiness, which may also contribute to sleep apnea, mostly obstructive. So the respiratory exam requires a systematic approach. As you already know, we inspect, palpate, and then percussion, and then auscultation. Before even touching the patients, we have to observe how they breathe, their work of breathing. Are they having any trouble inhaling or exhaling? Checking for any central cyanosis, which you can see on, you can look at they are external, their extremities. You can look at their fingers. Is there any change of colors on their nails, for example? Is it bluish discoloration? Are they using any accessory muscles to breathe? Is there any barrel chest? For example, the anterior and posterior ratio, which may be approaching like one to one, so which may indicate chronic hyperinflation. And this is a hallmark finding in patients, especially with COPD. Uh, where do we do our percussion? So this is percussion on different areas of the lungs, helps to establish whether the underlying tissues are air-filled. And then you can tell the difference based on their intensity, their pitch, or how long they last. So this is very important to differentiate these sounds, and it comes with time. For example, the dullness replaces normal resonance. Resonance is normal. Dullness would replace it when they have fluid or solid tissue, which can also replace the air containing lung. So this is seen, for example, in pneumonia. And hyperresonance is another one which may show any trapped air. This is also another common presentation, common sound in patients with COPD or tension pneumothorax. When we are auscultating, we do this every single day at our workplaces. So what are we assessing? The airflow dynamically through the tracheobronchial tree. So some of the sounds that you may hear are vascular sounds, which are the soft, low-pitched sounds which are heard over most lung fields. So when charting or documenting adventitious sounds, which are abnormal, we have to tell the difference between are they discontinuous, are they popping sounds of crackles, which are often indicate like fluid in alveoli, and then continuous or musical sounds of wheezes or rhonchi, suggest like a narrowed airways, or patients may also present with heavy secretions. So it's very important to tell the difference between these sounds. We often think like patients who wheeze are those with asthma, but also patients with, most of the times, patients with COPD and asthma may present with similar symptoms. You can also hear wheezing in patients with COPD. And so some of the special techniques that we can incorporate in our assessment, like the forced expiratory time for the detailed COPD assessment. This is beyond a physical exam, and it's a very critical aspect of health promotion. So we can advise patients about cigarette smoking cessation, as we mentioned, for the cardiovascular and peripheral assessment. And this is very important also for the health promotion of patients who present with respiratory conditions. And also, they may include like COPD, they may include sleep apnea, most of the times obstructive, and also, most importantly, immunizations. Making sure they're up to date on their pulmonary immunizations is very important to prevent the exacerbation of their conditions. So let's talk about the breast. That's in chapter 18. And for example, this is anatomy and physiology, which you already know, like a female breast lies firmly against the anterior thoracic wall, predominantly up over the major muscle, pectoralis muscle. So this is just a quick anatomy and physiology. The axilla, and then for the male breast, is clinically significant primary due to its rich lymphatic network, which drains the vast majority of the breast tissue. This is for the male patient. So when we're assessing the male breast, it's very important to look at any signs of gynecomastia, which is a benign enlargement of the glandular tissue. It can be purely physiologic, or it may be related to some medications that patients take. It can also be linked to liver disease or hormonal imbalance that may require clinical workup beyond what we may call physiologic. So a focused health assessment or for history, you should just inquire about, are there any lumps, presence of lumps, any pain, any nipple discharge? That's what we are looking at. What's the color? What's the consistency? So then for the physical exam, we have to give it more time for both men and women, and combine our own inspection and then with the multiple anatomical postures with meticulous palpation. This takes time, especially if it's the first time you see the patient, because you have to palpate all quadrants. And, for example, the talar spines, the axillary nodes, you will give it some time. It doesn't have to be rushed. But you will not be doing this during your video assessments. But in our second residency, we will give you an opportunity to assess the breast of and the axilla of standardized patients. So what could be the concerning breast findings? So during your initial inspection, did you notice any asymmetry, any dimpling, which may warrant immediate, attention, as this can be also early signs of underlying malignancy. Port d'orange indicates lymphatic obstruction if you see that, and then also severe edema. So any changes that you notice, like eczema or associated changes which you may note on areola, may represent Paget's disease. So it's very important to chart or to document the consistency of the tissue and any abnormal discharge that you notice, which is also known as galactorrhea. So also in your documentation for continuity of care and any referrals later on, it's very important to describe any nodules using standard clock face. Is it at 9 o'clock? Is it at 3 o'clock? And also estimate the distance from the nipple. And if you have enough time, and that's a good practice that we do at the clinical setting in the primary care, it's very important to measure the distance using a tape measure or anything else you use to measure the paper tape measure, just to when you are referring the patients to oncologist or any other specialist, they don't have to guess. And also look at the consistency of the nipple. Does it move freely? Is it fixed? And then also if they had any mastectomy or reconstruction. So this requires also careful assessment of the scar. margin, and then also assess the axillary assessment. All right, so this is the end of our presentation for this week. But we also talk about uh, health promotion, which is very important. And so we have to engage patients in comprehensive discussions about their individual, breast risks, including like cancer, educate them on mammography screening guidelines, breast self-assessment or self-awareness, routine clinical breast examinations, and remember those they are rare for men, they can also develop breast cancer. So preventative patient education is very fundamental as it applies to all demographics. We'll talk about another important aspect after patients develop like mastectomy or develop breast cancer. How can you talk to them? How can you address their concerns or their fears? Because sometimes uh, they don't even want to talk about it. This is a discussion topic for another day. Thank you.